welcome back from the break. If you just joined us, we're talking about depression today. I'm here with Dr. Nama, and before the break, the question was, is depression hereditary? Doc, tell us.
Yeah, so depression is different factors come together, but then hereditary definitely has a role to play as well. So our genetic component is there, and that research has found quite significantly. So you would notice that there are certain, not to be too technical, but then there are certain bits of genetic information or human information that are passed on from parents to children. And so in our family systems, these kind of come into play. And so sometimes once someone has a history of such a thing, it can increase the risk or the propensity of another person experiencing that a bit more with them as well. And interestingly, even suicide also has a genetic component as well. So these are things that happen that are the reality with which we live as well.
So you see, she's telling us the reason why we need to know something. Sometimes you wonder why you're asking if it is relevant to my family history, but the history helps you to even decide on what lifestyle changes or choices you make. Right, Doc?
Yes. And I think just going off track a bit, but I think, sometimes some people even allude to the fact that prior to our current present situation, initially when people are getting to marriage, families would really investigate about a lot of these things. And, well, they might not have been too far off. Sometimes they may not necessarily know the science behind it, but then maybe per observation, they didn't notice that there are some of these things that had some genetic components in there that can run in families. So that is it. Yes, there's some genetic components with.
But so if you have family history of depression, and people are going to be doing research about your family, I'm sure there'll be a stigma attached to this family. So is depression, can you recover totally from
cases? Yes or no? So there are some situations where, with the very first episode, based on how the case presents, considering the factors that might have precipitated that particular episode, and with management, some people would do very well and they'll go on, even learn some coping skills such that going forward they would not have another depressive episode. So that is possible. Then again, also there are, on the flip side, other instances where someone may be having a recurrent depressive disorder. So the person is predisposed to experiencing this in a repeated or recurrent manner. So they might have one, might be managed, gets well, but after a while they might have another bout of depression again, and another and another. So with such a person, they might need to be managed for a longer period of time.
Please walk us through the types of treatments you have for depression.
Okay. So with depression, I'll say the two main modalities are what we call the pharmacotherapy, or that's a big name for medication essentially. So there are a variety of medications we use to manage depression. And that is not the first line for something like a mild depression. So that one is more of moderate and severe kind of depression. Then we can draw medications to help manage that. And based on the type of depression you're managing, it will determine whether it's going to be really long term or the duration. But usually it's not lifelong per se, it's case by case. The other modality is what we call psychotherapy, where most people call a talk therapy. So it's used seeing a trained professional. So it's not like just doing a counselor or something, but someone who is really trained in the skill of psychotherapy. And even with psychotherapy, there are different types of therapies that would be administering based on the case that presents. So though it might look like you're just talking to the individual and the person is asking some questions and making you think and certain, discussing with you, and they're not writing or prescribing something, it's actually a structured therapy with some aims and goals with a particular time frame in mind. So, and that is one of the main treatment modalities. That's as for that, I think even something when we taper off medication, we'll still expect that will still be going on because it's really, really helpful as well. So those are the two main ones. Then there are on few occasions there are a few other interventions we might bring in. That's really when it's necessary. But majority of the time, these two are what we would do.
So this psychotherapy, is it also something like coaching? Because I kind of see similarities there. Please.
Okay. So with psychotherapy, as I said, so it's therapeutic techniques.
Okay.
So the addition, for example, with something like depression, one of the main things we'll be looking at is cognitive behavioral therapy. And that one stems from just basically the understanding that our thoughts affect our feelings and that reflects in how we behave. So if you're having certain thoughts in a pattern that is not too helpful, okay, or we notice some, we say cognitive distortions, where it's kind of, it's not in a light where it's helpful, but then it's kind of feeding and fueling all of these emotions that are negative, and then that's playing out in the behavior. Then the work is now to identify those and see how we can restructure all of those thoughts and then have it cascading into our emotions and our behavior. So it's a whole skill technique. So it's not just, I don't know how to, we can't downplay it. It needs someone who is a professional, who knows what they are doing. Um, and it involves not just even that session, but then given some assignments when you go home, do the ABC, observe what is going on with your thoughts, jotting them down. Different assignments homework come into play as well. And then the next session, all of those are discussed. So it's very personal, and it might, from the recipient's perspective, might look like, oh, we are just having a lot of discussions, but it's not just counseling, it's not just coaching per se, but it is really a therapeutic intervention. So once it's done well, then you have the positive outcomes. But if someone goes in and they go and just discuss, maybe there's something that happened, and without really looking into and dissecting, breaking it down into these phases, you might not really enjoy the benefits of the therapy. So that's just one form. There are other types of therapy as well.
And these are available in Ghana at your facility.
These are available. These are available. So even outside the psychiatry hospitals, okay. So yes, most of the psychiatrists will have a psychologist. Or sometimes a psychiatrist might do it with you. Sometimes a psychologist might do that with you as well. And then now we're having psychologists in different general hospitals as well. So they're not just in the psychiatric hospitals. So, and there are some private practices as well. So the service is available. And as I said, for mild depression, for example, it's just psychotherapy. There's no room for medication. Even talking about handling stress and a lot of other things, psychotherapy does a lot. So it's an important aspect of therapy. It's an important aspect.
Do you have instances where you diagnose somebody and they are in denial, they won't even listen and they won't come back? What do you do in such an instance?
It happens, especially when you're coming from even just the psychiatric hospital, setting. Then the friction might be a bit more. Sometimes, especially when it's not at the severe end, persons might not even show up voluntarily. There's relatives and others who have observed something that they are concerned about that might end up bringing the person. So the person will come and say, now, when you ask what's going on, it's like, oh, nothing, I am fine. They said there's a problem. So it does happen. It's a bit, so that's where professionalism has to come into play, where you kind of try and ease the person, make them comfortable, and then sometimes excusing everyone from the environment and trying to talk to the individual, explaining that you're there for their good, trying to help them be at their best. And not necessarily, and one, dispelling the myth that the fact that you're talking to me means you're mad. That seems to be a common thing. Like if they brought me here, they think I'm crazy, so that I'm here to prove I'm not crazy. So if you ask me anything, I'm not even going to answer, because some people think we are mind readers. Like my whole job is to prove a point that he is, off the rails. And so sometimes just communicating all of this so that the person can feel comfortable, and also listening a lot. Listen to what the person has on their mind. So sometimes it might not even start off, it might not even sound like an, how would I say it, like you are trying to diagnose depression per se. So it might be more of a conversational manner. How have you been these past few days? What's been going on? So it's just having a conversation. But then here and there, chipping in little questions, trying to pick up some of these symptoms. So that's where I think skill also comes in as well. So it's not like targeted like headache, kind of thing you're writing. But sometimes just putting a pen aside, having a discussion, conversing with the person, generally being interested in what's going on with the person, and then giving the listening ear so they feel comfortable. It might not all happen in one session. So sometimes just give me a break and say, oh, let's meet another time and then talk about it. Unfortunately, there are times where someone will not show up again. That does happen, and it becomes a concern.
Do you have a way of following up on them, or you can't really force anybody to get treatment?
Yeah, so that's we work within quality rights. So one, if The level of depression is, for example, severe. I think the person comes in and is deemed that this person is suicidal, this person is a high risk of harming themselves or harming another person, then irrespective of whether the person wants treatment or not, at least by law, we're given some time to admit for a period of time and then assess properly. And then if there's a need to extend that, go back to court and get all of that paperwork done. So once an individual is deemed a threat to themselves or to another, irrespective of what the person thinks or wants, at least we are given some room to admit for at least some 72 hours to assess and then see what we can do to intervene. But then when the person is not in that realm, then the person has a right. The person has a right to refuse treatment. The person has a right to say, I don't believe what you're saying, it's your opinion, I differ. I don't think I have what you think I have. And with that, I can't compel them and say by force you do. Sometimes what I would say would be to recommend they get a second opinion. I'll say, look, I'm not the only doctor here. I have other colleagues. And like sometimes when you mention a specific person, they might think you're going to discuss with them to kind of emphasize what you said. So I might just give some institutions and say, oh, I know there are doctors in A, B, C, in this 4 or 5 clinics, and say you can visit any of them. I think you generally have a problem that we can help. And so you can get a second opinion from these places. And if you're comfortable, you can always come back and then we'll discuss. So that happens. There are times, and that, as I said, is only in the space where I know the person is not in a place where they are at a risk to themselves or others. They are in a state where they are not a risk to themselves. That's when that comes in. There are times where you might have to discuss with family to see what for them might be helpful. Some people would be open to psychotherapy, talking to a counselor. Sometimes we try to just get insights. So we'll try to let them see this counselor and then the psychologist, sorry. And the aim is to help the person gain an insight of what's going on with them. Some people would open up to that and would go. There are a few others, they might even nod and say they'll go and they'll never show up as well. So sometimes we discuss with family and see how we can work with that person in mind. So it's not a general thing. It's very structured with the person in focus. Sometimes the person might have a person they actually listen to. You know, they might have some person that they really respect and would listen to the person's opinion. So you might have to rope the person in to help you get the support you need. So it's case by case, case by case. There are some other interventions as well that maybe I might not be
able to
say
yeah, because I was going to
everything
say it takes a lot of trusting, and so if somebody is comfortable with, say, a specific family member, is it possible to train them so that they are able to help the person cope? Because most of the time they are home anyway, they'll just come to you for appointments. So how does that situation pan out? And so I'm happy to know that your family members can actually be support groups for you.
Oh yes, yes. Sometimes we even do family therapies. There's a way the psychotherapy has different therapies in there. So sometimes it's family therapy, supportive therapy. There are lots of things. There are lots of interventions available.
Tell us the success story in Ghana. It seems very, but we just want to know some of the success stories so that we're encouraged, you know.
Oh, okay. I wouldn't know where to even start, but like there've been several. There've been several. So most people would come in first day severely depressed. You know, they are not even eating, they can't do anything, and you'd start your therapy first, second, third sessions, and they are back to themselves. So back to work, they are functioning, they are thriving, they're excelling. I mean, we get. I probably can't mention names, but then these are things that happen, and it's not. That's where we get fulfillment as well, because it's not all gloom. You know, you get to see people's lives get turned. People go back to school, and you know they flourish. Then you see them progressing, and then someone sends your wedding invitation. You know, these are the ups of the job, where you get to see that it's something that can be that debilitating, but then with intervention, people can still thrive and live life to the fullest. It's our joy to see that. And depression is not something that should be able to keep someone down, like to that extent. You know, there are a few cases that might be a bit difficult getting them back, especially when it lasts for a long period.
And you don't really know what causes
exactly. It. And then people have refusing and not adherent to their treatment, so they'll go off before we actually plan for the person to go off. Then the person has issues and all of that. So there are some challenging cases, but majority of persons really, really do well. some actually just not show up again. By the time they are not coming, you know that they are done well enough. You would have seen the progress. So
You gave an example of the depression being a subset of maybe some diagnosis you've had. For instance, you have cancer, you have HIV. So it doesn't change the fact that you have an illness that is taking your life, for instance. And with all the therapy, are you able to make them accept their fate more, or they just begin to trust that it's not the end? I mean, what goes on there?
okay, so that's also an interesting one. And with these, that's how come these therapies come in play, because how we all process these things varies. Yeah, so someone might have it and without even understanding, when someone hears something cancer, doesn't really know what the type of cancer is. Some might be actually having very good prognostic factors, meaning that outcomes might be very good. But the mere fact that I've heard that it is this,
I'm dying.
without even understanding what the nature or what the cause of the condition is, it's a first response. The person might start having all of those things. So sometimes even the education, the psychoeducation, educating the person about what the condition is and what the intervention, what the options are realistically, and what's the prognosis is, what the possible outcomes are, helps to give the person some better understanding of what they are dealing with. For example, even with HIV, now HIV we say is it's one of these, it's no longer a death
Yeah,
sentence,
you can live with
So
it.
once you start, and we say, oh, once you do A, B, C, D, adhere to your medications, you can actually have a very good life. We discuss how to manage family, all the concern. So essentially, it's a huge part is listening. Listen to the person's concerns, what their thoughts are, and then where there's some deviation from what is really the case, educate in that direction. Where there are actual cognitive distortions, then you might have to come in and then put in all that skill together. Sometimes it actually is a case of end of life. Sometimes
Sadly.
the truth is that the outlook is bad, and the person is not ready to go. And so discussing this and not trying to make it sound like, oh, that isn't the case. But
Can't lie
then,
to them.
yes, what can we do in the space of time that we have left? What are important during that time frame? Then discuss. So essentially listen to the person and then helping the person
Come to
come to
terms.
terms with what is going on and helping family as well. Helping the person also exit in dignity. So it's working with other teams. So it's not just the psychiatrist or the psychologist's job, but working with all the other teams that are involved in the management of the individual. So making sure that there's no pain, as much as possible. So like in that time, discussing with the patient, with their family, things we can do to help them cope better with the situation as it is. So it's really case by case, but that's generally the idea behind it.
I mean, listening to you, it's just the doctors just care. They just really care for our well-being, and they just want us to be at our optimum best. So seeking early medical attention is important. Yes, people might stigmatize us, but it's better to be healthy and have total well-being than to die and you still being stigmatized. So let's try and seek early attention.
Yes.
It's
And let's
very
also help
important.
break that stigma.
And let's break that exactly, because
It
once we
should be
have
normal.
understanding, yes,
Yeah,
we just learned that anything can cause. I mean, sometimes you
exactly.
don't even know what causes it. So we all can have depression. So
Exactly.
why should you stigmatize somebody else about it? Let's treat people the way we want them to be treated. Thank you so much, Doc.
Very good.
Any final words?
Ah. Well, I guess my final was always goes back to the same theme that it can happen to any one of us. It's not a moral weakness, it's not a spiritual failure, it's not all the things we kind of call it. It's not laziness. It's one of the conditions that just happens,
Happens.
and so we shouldn't feel inadequate when we are going through these things, and we should be comfortable enough to reach out for help. Reach out. And I always say you don't necessarily have to go to a psychiatric hospital. You go to the nearest health facility, and most doctors are trained to handle these. And if there's a need, they'll know how to liaise with specialist care. But if you can work in as well, that's great. I've had people working, and I'm always impressed by them. So we are here for you. I mean, always reach out, friends. And the outlook is good. We are here to help. Thank you.
Thank you so much, Doc. As always, it's been me, your host, Jacinta, and Dr. Nama. Have a good day.